Hi, it's Tom here from Running Physio. Today I want to talk to you about something that doesn't get covered very often in research and also in teaching, which is groin pain. And in particular, I want to talk to you about what helps us to guide return to sport after an athlete has had groin pain. And we're going to talk first of all about football and some new research there that should be useful for you. And then in the second half of this, we'll talk about some of the considerations we would have when working with runners. Now, there's a new research paper that's just come out, which is a Delphi study asking experts in groin pain what would be the things that they would consider important to assess to guide someone back to sport with adductor-related groin pain, which is one of many different potential causes of groin pain. So we're going to delve into some of their recommendations because I think they're actually quite useful in clinic to give us some things that we might want to think about. And then we'll go on to think about how we can use some of these principles when working with runners. Now, this research, as I said, is a Delphi study. So they go through a series of stages trying to develop the key strategies that most of the experts have consensus on. And let's have a look at some of the findings from this then. So this is a paper from Vergani et al. In the Sports Medicine Open Access Journal. One of the things they looked at, which you can imagine is important, is strength testing. Now, what they agreed was that for people coming back after adductor-related groin pain, not surprisingly really, that hip adductor strength was a key thing to assess prior to return to play, and to include within this isometric strength testing, such as looking at adductor squeeze test that many of you will be familiar with, and also eccentric strength testing. And they wanted to make sure that they had side-to-side symmetry when they were looking at their strength tests. Now, they talk mainly about adductor strength being key in this group, which is understandable, but they also mentioned that things like trunk flexor strength may be something to have a look at as well. Now, while they've reached consensus on adductor strength, it doesn't mean that there's nothing else that they'd want to look at, but these are perhaps some of the key things. Now, they're aiming for side-to-side symmetry, and I think that's probably a good first step for our strength testing because there's not a great deal of normative data out there to say that we must aim for a specific figure for every athlete that we see. But obviously, the larger the stress on the injured muscle group, the stronger that person may need to be. So it might be actually that you want to go beyond side-to-side symmetry in some situations, particularly if you suspect that there's weakness on the pain-free side, which there can be sometimes as well. Now, in this, they didn't reach consensus on whether these tests needed to be pain-free, but generally it is good if we can have pain-free testing of these muscle groups. It's more likely, I think, that they're going to tolerate return to play if these tests are pain-free. It might be in some situations low levels of pain might be acceptable, but ideally, really, asymptomatic would be better. So those are some of the strength tests that you might look at for someone wanting to return to play, perhaps in football, for example, where adductor groin pain is very common. Next up on the list were performance tests that they'd reached consensus on. So they agreed that this should include both planned and unplanned change of direction tests. And there are a number of different versions of these out there. And this is important, of course, because in sports like football, like rugby, like basketball, like many team sports where we might expect to see adductor-related groin pain, change of direction is very common, and it does place stress on that adductor muscle group. So we need to test that and see, is this comfortable for the athlete? And what they were looking for here is it pain-free with these performance tests? Can they manage planned and unplanned change of direction at multiple different angles? And does the athlete feel confident with change of direction? So we'd want them to pass these tests as well prior to return to play. And next up on the list was sports-specific skills. And I do think there's probably going to be a bit of an overlap here with some of the performance tests. And they, again, wanted the athletes to be asymptomatic and confident with sports-specific skills. For example, things like kicking a ball, which can be painful for adductor-related groin pain. And there was some debate, consensus wasn't reached over whether there'd be benefit in analysing the quality of movement and their ability to perform these skills. So perhaps looking at slow motion analysis of some of these sports specific skills, or slow motion analysis of change of direction work to see how it's being carried out, to see if there could be ways to perhaps optimize that to reduce the stress on the adductors. So we've got three quite useful areas that we might want to look at to guide someone back after adductor-related groin pain. Have they got the adequate strength, particularly in the adductors? Are they managing performance testing that's actually relevant to them, such as change of direction? Can they do sport-specific skills like kicking a ball? And are they confident and asymptomatic during those things? Now, one thing that was also discussed in here was imaging. Do we need to have imaging for return to play? Well, actually, in the study, they said the experts strongly agree to not consider or include imaging methods among return to play criteria. So it seems in this particular study of return to play, at that stage of treatment, they didn't feel that imaging was needed to clear people to return to play. Now, it might be that they'd have had imaging earlier on in that process, but we don't need a scan to be clear necessarily to guide return to play for every patient, providing they're achieving some of those tests. But as with everything, it's always going to be specific to the individual. So that's a really nice Delphi study, open access from Vergani et al. And I will include a link to that in the comments beneath this. So do check that out, make your own conclusions on that study. They mentioned a little bit too about other tests, like looking at intersegmental control with things like single leg squats, or looking at flexibility. And while they did agree there could be benefits at looking at some of these tests, there wasn't a consensus reached on them. So it's important to recognize with these Delphi studies, this isn't everything. This isn't saying these are the only things you would look at, but it's the experts in the field agree that these are useful things for return to play. Now, this is probably mainly applicable to those in sports where adductor-related groin pain is common, like we said, football and sports that involve a lot of change of direction. But what about our runners? Now, of course, you know that that's my passion, is treating runners and running injury. And I think there's a few different considerations when you're working with runners if they're coming in with groin pain. So number one would be to be suspicious that there might be an underlying bone stress injury. Now, the adductor load in runners generally is going to be less than it would be in football players. Particularly at endurance speeds. It is going to be higher at sprinting, but at endurance speeds, hip flexor and adductor load is relatively low. So seeing a true adductor tendon pathology is a little bit less likely. They do happen, but it's a bit less likely. What we do see, though, is things like femoral neck bone stress injuries, femoral neck stress fractures, or pelvic stress fractures like pubic rami stress fractures, and both of those can present with groin pain. So I think first up, we need to have that suspicion in our mind, particularly in at-risk groups, those who've had previous bone stress injuries, those that have predisposing factors, perhaps low BMI and other things that will influence bone health. We should be prepared to look into it a bit more. And this is where actually imaging would be appropriate. So if you suspect that there's a femoral neck stress fracture that's causing those groin symptoms, it is appropriate to arrange an MRI, because those are high-risk bone stress injuries that can progress to a true fractured neck of femur. So if you suspect that, if in doubt, get it checked out. So it is a little bit different with our runners, different populations, different injuries. And of course, there are other causes of groin pain in runners. Yes, it could be adductor related or hip flexor tendinopathy. Those do happen, but as we said, they're less common. It could be intra-articular hip pathology, such as something simple, potentially, such as some osteoarthritic change. Well, I say simple, but relatively simple compared to some of the more complex anatomy and changes in that region. It could be some labral pathology there. There may be intra-articular causes of groin pain. Now, typically we might expect with those to see pain during hip range of movement testing. So quite often at end of range flexion, and very typically in internal rotation tests, they will often bring on symptoms in sort of hip joint related pathology. You'd expect pain too with things like flexion, adduction, internal rotation tests. So that might help with this differential diagnosis. When it's adductor related, you're going to expect pain when that muscle group's under stretch, but also when we're testing those adductors, if you're looking at things like your adductor squeeze test. But again, there's often some red herrings here. So I've seen a number of cases now where people have had a pubic rami stress fracture and have had pain on adductor testing too, because it's also putting stress through the pelvis. So it's having that suspicion there, and if in doubt, get it checked out. Now, one of the things I like about this Vergani et al. Paper is that it's thinking about the need of the athlete to ensure a successful return to play. And if there's one thing I'd like you to take from what we're talking about here, is try to do that with your patients. Try and really consider the needs of each individual, what they need to achieve for return to play. And particularly in those who've had history of persistent injuries, or they've tried to return to running or their sport several times and have had setbacks, we do need to plan that return to sport a little bit more carefully. So think what tests of strength, of performance, or sport specific tests are going to be useful to include for that person, and then plan some return to running criteria with that person. And I do feel it should be with them, not for them. So some of the things that we might look at to give us a good indication that someone is ready for return to running would be things like low irritability, so able to walk for half an hour with no pain. Able to manage impact, which is obviously a key part of running. So you might include that in your sport specific testing. So that could be jogging on the spot for a minute, jumping in place, bounding, going up to repeated hopping, to show us that that person is capable of managing impact. And then you might have some specific strength tests relevant to your pathology. So perhaps someone with Achilles tendinopathy, we want to see that the calf strength test is equal left versus right. Again, using side to side symmetry as a little bit of a guide. So you can think through and set some of those return to sport criteria with the person, and then you can plan your rehab to address those needs to prepare them for return to sport. And I do recommend doing this, particularly in more complex cases. And then you can start to think about how you can bring people back to their sport. And what we consider to be gradual return to sport may be very different from other people. So for some runners, when they've said, I've done a gradual return to sport, that may mean that by week 2 of their return, they're back running 6 days a week. That might feel gradual for them, because they're used to running 10 times a week and doing higher intensity sessions, longer sessions, strength and conditioning. That might not feel very much, but that's still quite a big leap if they haven't been doing any running for several weeks. So once we've achieved those return to running criteria, we need to have a plan in place that then builds people back up successfully towards where they want to be. And that's probably a big difference between return to running versus return to football. With return to running, you can start people with a few minutes. And actually, it's often very sensible to do that in irritable cases or ones where they've actually struggled with that process several times. With return to competitive sport like football, ultimately you need to get them back to being able to compete for 90 minutes. It's more difficult to control the volume and intensity of that return. There's more challenging demands in terms of change of direction, so it makes sense to have a slightly more in-depth return to sport process that tests those things out before you get them back in. Now, the final point I'd like to make on this is when you're returning people to running in particular, do be aware that sometimes we can set unnecessary and unrealistic goals that form a barrier to return to sport, an unnecessary barrier for return to sport. So an example recently, someone was told they must be able to do 50 single leg calf raises before they can return to running. Now, I don't know about you all listening in. I can't do 50 single leg calf raises. My calf won't let me get anywhere near that. Lots of runners would be very happy getting close to half of that. So let's not set unrealistic goals. Let's make them specific to the individual. Let's make them realistic. And that's where probably side-to-side symmetry as part of that can be quite helpful, rather than having an arbitrary target that actually ends up being a barrier for return to sport. Okay, I hope you've found this interesting and it's given you some ideas about return to play testing. I'd like to hear what you think on this. Is there anything else that you would want to test with people prior to return to sport or return to running? Do you think we need to be more diligent with it? Should we be stricter with our runners to hit these targets to get them back? Or perhaps you think the other way. It's just a simple question of starting some running when they feel ready to do so and building the running gradually. Because ultimately, if you want to run, at some point you've got to actually run and build it up. And that hopefully will encourage the body to adapt to it. So let us know what you think in the comments and replies. I've left a link in with a title to our free videos. We've got videos on Achilles tendinopathy, lateral hip pain, lower back pain, ITBS, loads more for you that you can access by clicking those links if you'd like to find out more about getting great results with running injury. Okay, thanks again for listening. Bye for now.